Now, it is my privilege to present our opening keynote speaker. Our opening keynote speaker is Dr. Stephen Nissen. He is the chairman of the Department of Cardiovascular Medicine at the Cleveland Clinic and professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western University. In 2006-2007, he served as president of the American College of Cardiology. Dr. Nissen's many contributions to obesity research is the foundation for subsequent breakthroughs in understanding the disease of obesity, and we are honored to have him as our opening speaker for Obesity Week 2018. Please, a warm welcome to Dr. Nissen. Thank you so much.
Thank you so much. Well, thank you very much for that kind introduction, and thank you all for being here. You know, I must compliment the obesity community for bringing together the medical and surgical sides to this disease. We haven't been able to do that in cardiovascular medicine. You know, our cardiothoracic surgeons and cardiologists, we almost never meet together. And I think you've really set a shining example for how it ought to be done. So thank you for doing that. It's a challenging talk for me to give when I'm in a room of people who know a lot more about obesity than I do. So I'm going to walk through sort of a top-line view of this relationship between obesity and cardiovascular disease and talk a bit about the pathophysiology and the epidemiology of it, because in fact, heart disease is how obesity kills most of our patients. That's still the leading cause of death, and we are going to have to tackle this. Before I came here, I walked through our coronary care unit and I calculated the BMI of the patients in the CCU, and it was 34. That was the median BMI, with some people, you know, well above 40. So we are taking care of the same patients, and we need to work together and collaborate if we're going to make progress. My disclosures are shown here on this slide. So the question is, how important is obesity as a risk factor for coronary heart disease? Believe it or not, this has been over time a bit controversial. I think the best data comes from the Interheart study, which was a case control study in 52 countries of acute MI. Every continent represented about 30,000 patients altogether that looked at risk factors and myocardial infarction. And here you see forest plots. And all the usual characters are there: smoking, diabetes, hypertension, but right up there is abdominal obesity with about a twofold increase in the risk of myocardial infarction. So that obesity clearly is, in my view, unquestionably an independent risk factor for myocardial infarction. Let me actually show you how important obesity is. If you look at the first three, smoking, diabetes, and hypertension, you see odds ratios in the 2 to 2.5 range. Obesity similarly, but look at the bottom line. If you smoke, have diabetes, and have hypertension, and you add obesity, your risk of an MI goes up 21-fold. There's not a lot of diseases that we see where you can have that kind of an amplification of the effects of these other risk factors, and that's what obesity does to our patients. Now, the question always is, you know, the most important outcome is mortality, and we have mostly data on all-cause mortality rather than cardiovascular mortality, but let me show you what the best data look like. Go back 20 years. Pivotal paper in the New England Journal of Medicine 20 years ago that showed the relationship between BMI and mortality. And you all know these data probably better than I. It's somewhere in the range of 22 to 25. Things look pretty good. And then as you go to higher BMIs, there's a progressive increase in the risk of death. One of the things that was raised, however, for this paper is the increased hazard ratio in BMIs as you go below 20. And I'm going to talk a little bit more about the so-called obesity paradox, because I think it has confused a lot of people in my field and perhaps maybe a few in yours. In fact, if you look at midlife BMI and mortality in an older age, one of the observations that I wanted to emphasize here is as you go from left to right, from low risk to high risk patients, obesity is still a major factor, even if you're at low cardiovascular risk because of other risk factors. And you see a 1.43 hazard ratio in low risk patients, and it goes up from there as you go to higher risk. What it means is nobody is immune. Even if you're a low risk cardiovascular patient, you're still at risk if you have obesity. And then the problem arose that data challenged these findings, and the specter was raised of the so-called obesity paradox. And let me walk you through a little bit of what caused people to raise this concern. Here's a paper from JAMA 2013, a very prestigious journal. And it was a meta-analysis of all-cause mortality and BMI, showing that there were relatively reasonable mortality rates with high mortality in the group with a BMI of over 35, but people who had a BMI of 30 to 35 actually had a less than 1 hazard ratio of mortality. And I know you guys are going to find this conclusion bizarre, but this is what the authors concluded in this JAMA paper. Grade 1 obesity overall was not associated with higher mortality, and overweight was associated with significant lower all-cause mortality. It's got a lot of press, there was a lot of buzz about this, and of course it confused our patients, primary care physicians, and many others. And then it gets a little bit worse because there is all this literature in cardiology that if, for example, you have heart failure, you have a better survival if you're obese. And if you look at these curves, you see that the overweight and obese patients at the top here are the ones that actually have the best survival, and underweight patients have the worst survival. And so we had colleagues saying, well, it's not so bad. If you have heart failure, it's not so bad to be a bit overweight. You know, maybe you'll live longer. This is now 2 weeks ago on CNN. You will see this report that said that obesity and having a low BMI are linked to increased risk of death, study reveals. And you know, I'm sure some of you saw this. I certainly caught my attention. It turns out that it's a very big study, 3.6 million patients from the United Kingdom, and they followed patients in general practice clinics for 11.6 years, and they had BMI data collected at ages greater than 16, and then they were followed up. What they reported here in Lancet Diabetes is that there was a nadir of mortality at a BMI in the mid-20s, that it goes up with higher BMIs and it goes up with lower BMIs. And that was why this conclusion was suggested that somehow or other you can be too thin. Here's the actual years of life lost. And I think it's actually most useful to look at the obese population. But in this 3.6 million patient database, if your life expectancy at age 40 was reduced, if your BMI is over 40, by an astonishing 9.1 years. That is just an enormous effect. It's a little bit less for women, but it's 7.7 years for women. But they also reported that your BMI, if it is low, also had an increased mortality. So how do we reconcile all of these data? Well, it turns out that there are a lot of flaws in the research that suggests that there's a paradox here where obesity might actually be protective. And if you haven't read it, there's just a terrific analysis out this year. It's in JAMA Cardiology. And here's the difference about this study. Look at the time horizon here. So a lot of the studies that raise the confusion about the impact of obesity looked out 5 or 10 or even 11 or 12 years. Well, if you look on the left side there, you can see that in the first, say, 15 years of follow-up, those curves are relatively closely clustered. But as you go out to 20, 25, 30 years and more, this risk of morbidity and mortality, this happens to be the data for men, there's very similar data for women, shows a very striking and consistent relationship between weight, BMI, and mortality, and there is no excess in mortality. And in fact, the underweight patients actually are living the longest. So we say you can't be too rich or too thin. And I think that that's right. When you look at the totality of the data, you really don't see evidence, unless you're really grossly underweight, you don't see evidence that being thin is somehow harmful, as was suggested by some of these manuscripts. And here's actually the data in women. So the three key issues with the obesity paradox is that it's confounded. For one thing, it's confounded by smoking, which is associated with low body weight, but high cardiovascular risk. The time horizon has to be long enough to observe the full effects of obesity. And that some individuals, this is key, with a low BMI are very thin because they have other chronic or incipient diseases. You know, somebody that has an unrecognized cancer may in fact be relatively underweight. We just don't know that they have that underlying disease. And so I'd like to tell you that as I look at all the data, I am convinced that having a low body weight is healthy, not unhealthy. Now, what about other cardiovascular diseases? You know, we focus on coronary disease, but we are seeing more and more recognizing that obesity is related to many other of the diseases that we see. Congestive heart failure, particularly diastolic heart failure, and these are the data in men, show you, this is actually from Framingham, that again, over a long time horizon, there's a very striking relationship between developing congestive heart failure and body weight. I wished I had time to go into all the pathophysiological aspects of this, but suffice it to say, the patients that you see and that I see that are obese are at markedly increased risk for congestive heart failure. There are other disease entities that we see that are also closely linked. Stroke goes up, heart failure, this is again another study showing very striking increase in heart failure, and of course, as we all recognize, coronary artery disease. And please note here that the lowest rates are in people who actually have normal body weight, and that includes people who are very, very thin. Atrial fibrillation is increasingly recognized as one of the major consequences of obesity. And here you see, and for both men and women, a very striking relationship. Keep in mind that atrial fibrillation is the harbinger of a lot of other bad things like embolic stroke. And so we need to be cognizant of this, and we need to be careful that when patients who are obese have episodes of palpitations and other symptoms, we need to look carefully because they may have unrecognized intermittent atrial fibrillation, which represents a risk factor for the development of stroke and other consequences. I suspect that there are many people in this room that are focusing their attention on childhood obesity. And I find these data from 2011 from the New England Journal to be particularly interesting. It's a pretty good sized a cohort study, actually 4 studies pooled. And what you see is that if you have only childhood obesity, there really is not a major risk of diabetes, hypertension, low HDL, or hypertriglyceridemia. But if that obesity carries forward into adulthood, that is, if you have both childhood and adult obesity, you have an increased risk, just as you do if you have adult obesity. Why am I showing you this? Because it's clear that early intervention is just critical. If we can identify young people, children and adolescents with obesity, if you look at the group in orange, where they were obese only as children, they are able to recover and not have the kind of increased risk that we see in people whose obesity carries forward. And so I personally think one of the public health focuses needs to be to keep thinking about working on all the things we are trying to do, you know, with school lunch programs and exercise programs. And one of the things that's really kind of tragic is a lot of the physical education is actually getting less attention in the schools now rather than more attention, and I think that's a big societal problem. So here's a big controversy. Does fitness reduce or eliminate adverse cardiovascular outcomes associated with obesity? Can you be fit and fat, and does that mitigate the risk? Well, you can look at a lot of data. This is certainly one of the better studies. It's 25,000 people that looked at fitness and fatness. And what I want you to see is, if you're not fit, that's the blue triangles, your hazard ratio for developing cardiovascular disease is very high. If you, however, are fit, you still have an excess risk if you're obese, but it is actually reduced fairly substantially. Why do I show you this? I recognize that it can be very difficult for people to lose weight, but if we can get them to exercise, we can reduce some of that cardiovascular risk. And I do have a few patients, not a lot, but some, that are obese, but very, very fit. And I encourage them because it is a way to at least partially reduce the consequences of their obesity. What about metabolically healthy obese patients? So, you know, the question is, if you don't have any of the comorbidities that are associated with obesity, does that mitigate risk? So this is from the EPIC study. It's 500,000 person study, and it looked at metabolic dysfunction as having any one of the 5 things listed here: blood pressure, triglycerides, low HDL, hyperglycemia, increased waist circumference. You know, what is the impact if you have none of those things versus having many of those things? If you have more than 3 or more of those things, you're considered metabolically unhealthy. Again, followed for 12 years, and it's 7,000 coronary cases, so it's a pretty big cohort. And here's what you see. Those people that are metabolically unhealthy have very elevated risks, which are proportional to their degree of obesity. The metabolically healthy patients also have increased risk, but the risk is, in fact, somewhat lower. Now, the reality is that there's not an excuse for people not to be thin. Clearly, there is increased risk, but the people that need the most urgent attention, the people in whom I might recommend bariatric surgery, are the people that are obese and have all of these metabolic comorbidities, because they're the ones that are going to have the major cardiovascular morbidity and mortality effects from the obesity that will shorten their lives and reduce the quality of their lives. So how does obesity cause cardiovascular disease? You know, it's not as apparent to everybody, but I think we know at least some of the factors. My own view is that the common soil for atherosclerosis in these patients is insulin resistance, because insulin resistance is associated with hypertension, clearly obesity, hyperinsulinemia, diabetes, hypertriglyceridemia, small, dense, low-density lipoprotein cholesterol, a low HDL, and a hypercoagulable state. All of those things drive toward atherosclerosis. I'm going to show you some data for some of these things. So Elliot Jocelyn was pretty smart. Elliot Jocelyn said, with an excess of fat, diabetes begins, and from an excess of fat, diabetics die. 1927, which is really pretty prescient. And I need not tell this audience, you probably know this better than I do, how extraordinary the relationship is between BMI and incident diabetes. And diabetes has many consequences, but the most grave amongst them is cardiovascular disease. As I showed you earlier, clearly an enormously important risk factor. And once you get to a BMI of 35, the relative risk for type 2 diabetes relative to a BMI of, say, 22 or 23 is just enormous. And so one of the ways that obesity leads to cardiovascular morbidity and mortality is clearly diabetes. And it is important that we all understand, and I think a lot of cardiologists don't, you probably all do, that it is abdominal obesity that seems to be the disproportionate factor here. It's not just body weight, but it's having a distribution of fat in the abdomen. Abdominal obesity is associated with elevated cardiovascular risk. Obviously, it overlaps with obesity and also with inflammatory risk. We like to follow high sensitivity C-reactive protein, and I'm particularly interested in knowing what it is in patients that are obese because it often is strikingly elevated. Part of the reason for showing you this is there are therapies now in the pipeline that directly target inflammation as a way to mitigate risk. And that's something that I think we're all going to be paying a lot of attention to in the near future. So I think almost everybody in this room is well aware of these data, but the distribution of fat. On the left, you have the subcutaneous obesity, so-called healthy adipose tissue. I don't like that term. I suspect you don't either. But they do better than people that have visceral adiposity because the visceral adiposity patients are the ones that have altered free fatty acid metabolism. And the fat cell, I think we've come to recognize, is a metabolically really important and active producer of adipokines, cytokines that then lead to altered metabolic profiles that then subsequently lead to cardiovascular disease. So we like to talk about the concept of cardiometabolic risk. And it's a constellation of findings, some of which are used as research tools, but some of which are easily measured. Visceral adiposity, insulin resistance, dyslipidemia, that is high triglycerides, low HDL, small dense LDL, hypertension, impaired glucose regulation, inflammation is critically important, impaired fibrinolysis, increased free testosterone, decreased adiponectin, and non-alcoholic fatty liver disease. This constellation is driving a lot of the diseases that are the consequences of obesity. BMI alone is an imperfect predictor. And I think if you go back and look at some of those early slides that I showed you where there's some confusing data suggesting an obesity paradox, keep in mind that that was BMI data. That wasn't waist circumference data. I think it might have been a cleaner interpretation of the epidemiology if waist circumference had been used. But what I wanted to show you here from these data is that for any given BMI, there can be quite a wide range of different waist circumferences. So somebody whose BMI is, say, 32 may have a waist circumference that's well under 100 centimeters. They're not going to be, obviously, at much risk. So the people, again, that I'm really wanting more urgently to get the best possible, most effective weight loss treatments are those people that tend, presumably for genetic reasons, to accumulate visceral fat. They're the ones that are going to have the biggest risk. This shows you how the data plays out. So let's take the lowest tertile of BMI, less than 24.5. Think about that for a minute. Somebody who's got a BMI of less than 24.5, who has a high waist circumference. Look at the hazard ratio, the far left graph. It's almost 2. And if you then go to the highest BMI tertile in this particular analysis, you see very similar risks. And so what it's about is that if you're thin, but you have a high waist circumference, if you have a moderate BMI, but you have a high waist circumference, you're still at very substantial risk. And those people need to be targeted for treatment. It also depends on your ethnicity. And I know there are probably people in this room that have studied this a lot more than I have, but I reviewed a number of papers in preparing for this talk. And this is a particularly well done study that shows that the glycemic effect of obesity is comparable for South Asians at a BMI of 22.6 as it is for white Europeans at 30. And so we see these patients on the coronary carrying it all the time. Asian Indian male, often from the south of India, that comes in, their BMI is not high, but they've got that tummy bulge, little kind of tummy bulge with increased visceral fat, and they have premature coronary artery disease. And so I think we have to be cognizant of the ethnic relationships here, because it really does determine what's going to happen. One of the ways that obesity drives cardiovascular disease is hypertension. It is an incredibly powerful risk factor. This shows the relationship. This is a nurses' health study, which is, it's older, but it's really well done, showing that, in fact, the relative risk of hypertension, once you get to a BMI of about 30, this is data from the mid-1990s. They didn't have a lot of people above 30. We do now. You have a fourfold increased risk of hypertension. And you see that, by the way, also in the health professionals study, which was in men. So clearly, one of the key drivers here is blood pressure increase. Why am I showing you this? Because if we treat these patients, they need to have their blood pressure aggressively managed. It is one of the ways that this disease is driving excess risk. This shows the odds ratio for hypertriglyceridemia. And so triglycerides are now increasingly recognized as a major atherogenic risk factor. In fact, I could talk with you for an hour about hypertriglyceridemia. It's really becoming important. And it is directly linked to weight, to obesity. People whose BMIs are over 30 have an odds ratio in the range of 4 to 6-fold increase in the likelihood of a triglyceride level above 150, which is where the cut point. You may also know that I just came from the American Heart Association, where a clinical trial showed really for the first time that treating patients with hypertriglyceridemia can actually mitigate the risk. So we're getting some data to suggest that this is a target for treatment. Why are triglycerides important? Because the epidemiology is really just as clear as it could be. This is now older data going back 30 years to the Framingham study, showing that for both men and women, as triglyceride rises, so does the risk of coronary heart disease. The ways that triglycerides lead to coronary heart disease are not as clear, not as well evolved as they are for, say, LDL cholesterol. I think many of you realize here that actually obese patients tend not to necessarily have elevated LDL cholesterol. They tend to have elevated triglycerides, but it is an important risk factor. One of the things that we see, there are a lot of people who are spending a lot of money ordering very fancy lipid panels, doing NMR and other techniques to look at particle size and particle number and so on. Actually, you don't need to do that. All you have to do is look at the triglycerides. If the triglycerides are elevated, the likelihood that you have this so-called atherogenic phenotype, where you have small, dense LDL, the likelihood of that phenotype goes up, that's called phenotype B, as your triglycerides go up. Triglycerides are an incredibly powerful predictor of having more atherogenic LDL cholesterol. Why do we care about this? Because if you have this small, dense LDL, it has increased particle numbers for a given LDL level. It's associated with high triglycerides and a low HDL. It's probably genetic, but it's also clearly environmental. And what happens is these smaller, dense particles have greater arterial uptake, greater uptake by macrophages, and they're increasingly susceptible to oxidation, which is why they're more atherogenic. So the high triglyceride patients don't have a higher LDL, but they have a more atherogenic LDL, and that's why they get accelerated disease. Increasingly, in recent years, there has been a focus on the importance of high-sensitivity C-reactive protein. It's a powerful, powerful predictor of risk. And what is not often talked about is it is driven in significant portion by obesity, particularly abdominal or visceral obesity. Presumably, the mechanism is, I think, reasonably well understood, that adipokines produced in the visceral fat are then circulate to the liver, where they drive production of IL-6, CRP, and all of the inflammatory markers. And you can see here in both men and women this relationship between BMI and inflammation. Inflammation due to obesity is probably one of the ways that atrial fibrillation is driven by obesity. Here's data from Archives of Internal Medicine from a while ago that looked at a bunch of clinical trials, and it looks at the relationship between baseline weight and CRP. And you can see surgical trials. You got a joint group here, so it's surgical and medical trials. The medical trials in blue, the surgical trials in gold, and you can see this very striking relationship between mean baseline weight in kilograms and the level of CRP shown on the vertical axis, with a pretty good correlation coefficient of R equals 0.76. Later on, I'm going to show you what happened in these trials when people lost weight. Can weight loss favorably affect risk factors? This is obviously of high relevance to all of us who treat obese patients. What can we say to our patients about the effects of weight loss on the risk factors that they have for this disease? So let's look at triglycerides. This is from the Look Ahead trial, and again, not a lot of weight loss, but what you see is that if you gained weight or lost just a little bit of weight, not much happened. But if you lost 2 to 5% of body weight, you see about a 10% reduction in triglycerides. If you lost 5 to 10%, now you're up to about 30% triglyceride reduction. And if you lost 15% or more, you see a whopping 70% reduction in triglycerides. And so we can get people to lose weight, their triglycerides go down. And in fact, in our guidelines, just rolled out at the American Heart Association meeting, it's absolutely mandatory that in people with hypertriglyceridemia, before you treat them with drugs, treat them with weight loss. Get them to lose weight. What's also interesting, and I think we've always been puzzled by this, but not much happens to LDL, shown in the blue triangles. But as you lose weight, particularly if you can get in that 10 to 15% weight loss group, high density lipoprotein cholesterol, HDL, goes up. Look at the p-value here. It's less than 0.001. There is no relationship between weight loss and a reduction in LDL. It's not a way to control LDL. Fortunately, we have statin drugs and other ways to control LDL. But the bottom line is that we can, in fact, raise HDL with weight loss. It takes a little bit of time, and it doesn't take a huge amount, but you can get HDL to go up. What's probably the most remarkable is what happens to blood pressure. I want you to see from this study published in Annals of Internal Medicine a few years ago that these are quintiles of weight change. And so if you look at the people in the second quintile, they lost 2.6 kilograms of weight. So you have men and women shown here. And please note that blood pressure is down as much as about 5 millimeters of mercury. You may think that's not very much. On an epidemiological basis, it's huge. A 5 millimeter blood pressure reduction is a major reduction in stroke and myocardial infarction. And if you can get people to lose just 8.8 kilograms, you have a very, very substantial reduction in blood pressure. And so one of the things we can say to our patients is that if you can just lose that first 10 pounds, you're gonna maybe not require more blood pressure medications. You may even be able to back titrate a little bit your blood pressure medications. The burden of these medical treatments is very high for patients, and even a little bit of weight loss goes a long way in the world of hypertension. Cochrane analysis 2011 showed what I think is probably as reliable data as you're going to see. Looking at 8 studies, you see that a 4 kilogram weight loss was a 4.5 millimeter reduction in blood pressure. So for every kilogram, you get about a millimeter of mercury. 4 kilograms, 4.5 millimeters of mercury. And again, that's not trivial. That on an epidemiological basis, that is a really important point. That very minimal weight loss significantly reduces blood pressure in obese patients treated with diet alone. So we don't need more radical treatments in order to get there. Now, what about the effect of bariatric surgery? Dr. Kashyap, who has worked with me and with Dr. Phil Schauer at the Cleveland Clinic, has a wonderful endocrinologist. She published results from the Stampede trial that Phil led. And I want you to see how big the effects were on metabolic risk factors. Obviously, HbA1c, a 3.1% reduction with gastric bypass is just amazing. But HDL went up 13.8 milligrams per deciliter, and triglycerides went down a whopping 56 milligrams per deciliter, and CRP went down 2.6 milligrams per liter. Those are just huge changes in the metabolic risk factors. And so clearly we have evidence that if you can get people to lose substantial weight, you can normalize these metabolic risk factors that are likely the major drivers of coronary heart disease. What about CRP? There's also really good data. This is a study of 83 women. It's not big, but basically it's diet alone for 12 weeks. They got a pretty good 8 kilogram weight loss, and CRP went down by 26%. So again, this inflammatory risk can go down. They also showed a reduction in triglycerides. I mean, clearly weight loss is an effective way to reduce the inflammatory risk. And the higher the CRP, the higher the cardiovascular disease. And then this is another analysis of a whole series of trials. The medical trials shown off at the right obviously had less weight loss. The surgical trials had very substantial weight loss. And you can see that there's just a striking high correlation relationship between the magnitude of weight loss and the reduction in the inflammatory risk that is one of the key drivers of coronary heart disease, as shown here. Can diet or drug therapy favorably affect atherosclerotic cardiovascular outcomes? To me, ladies and gentlemen, this is the holy grail. To what extent can we show the world that if we can get people to lose weight, we can mitigate the risk? And I know you all know Look Ahead. You probably know it better than I do. It was an expensive, intensive study done by the NIH. These people had decreased caloric intake and increased physical activity. They had coaches. They had tremendous amount of energy on this. They were not very effective, but the primary endpoint was the composite of CV death, non-fatal MI, non-fatal stroke, or hospitalization for angina. They followed these people for up to 13 and a half years. a median of 9.6 years with only 4% loss to follow-up. So it was a pretty good quality study. The weight loss was, and I don't really understand what went wrong here, but the weight loss really, while it was pretty good in the first year, wasn't sustained. And so the total mean effect was 4 kilograms. So all this energy, all this effort, tens of millions of dollars spent, and they only got 4 kilograms of weight loss over 10 years. And there was no effect on the primary endpoint. And so, I'm sure you were disappointed. I was disappointed, but we have to understand that the trial failed not because weight loss isn't good. It's because they didn't get very much weight loss. And we probably need to understand strategies better, but this was a strategy, and however it was done, I'm sure some of you here were part of Look Ahead, it just didn't work out. And then we have the sad sibutramine experience. I think some of you have been around long enough to remember this drug, approved in 1997. Some modest weight loss, improved biomarkers. The European Medicine Agency required these investigators, required the company to do an outcome trial, which was called SCOUT. It was done by regulatory mandate, not because it was decided that this would be a good thing to do. It had a classical cardiovascular endpoint, death, MI, stroke, and resuscitated arrest. People had to have high cardiovascular risk and a high BMI, and they were excluded if they had blood pressure increases or heart rate increases when started. And I suspect many of you who give catecholamine drugs are careful about watching the heart rate and blood pressure. The weight loss was not very impressive. It was 1.7 kilos. And again, very disappointing for those of us that recognize. I mean, these are people that are obviously very much more overweight. 1.7 kilograms isn't a lot of weight loss, but nonetheless, this is what they saw, 10,700 patients. Blood pressure and heart rate go up. And one of the things I can tell you is that heart rate blood pressure product, or the rate pressure product, is a pretty important factor in heart disease. That's why I showed you all the hypertension data. So increasing heart rate and increasing blood pressure is not a good thing in people who have heart disease or are at risk. And what happened is what I would have predicted is it was a statistically significant 16% increase in the composite of cardiovascular death, MI, or stroke. So here was a drug where they got some weight loss, but they actually increased cardiovascular morbidity and mortality. We can't forget about this. We have to pay attention. And in fact, diabetes actually got worse. There's actually was a statistically significant increase in HbA1c. So giving a sympathomimetic drug to people that are obese actually made diabetes worse. It's exactly the opposite of what we should see with weight loss. Now, not everybody in this room is going to like this slide, but I don't shy away from it. Phentermine, I know, is widely used. It has many similar effects to sibutramine on blood pressure and heart rate. It's never been studied for cardiovascular outcomes. And although this drug reduces weight, I think there is considerable uncertainty whether it increases cardiovascular outcomes. Ladies and gentlemen, you know and I know that obesity is not so much the cosmetic problem, it's a problem of morbidity and mortality. And so giving people phentermine, they may lose weight, but I cannot tell you whether or not they're going to actually increase their risk of cardiovascular morbidity and mortality. And so I think and no one's going to do this study unless we push for it, but it has to be done. We need to know whether other sympathomimetic drugs are going to do what sibutramine does before we treat many patients with these agents. Lorcaserin did do an outcome trial. It was mandated by the FDA, and they lost very small amounts of weight over 40 months, 1.9 kilograms, and there was absolutely no effect of lorcaserin on morbidity and mortality. And so it's very hard for me to argue in favor of giving any of these drugs. I think we have to demand that the obesity drugs do outcome trials, because the only way we're going to know what's good and what's bad is if we study it. Now, the good news is some of the makers of the GLP-1 agonists are doing such studies, and I applaud them, and I encourage them, and I hope you will participate in those studies because they're going to give us some answers. So in this slide, I'm going to show you the established benefits of weight loss drugs on clinically important outcomes. This slide is intentionally left blank. And the reality is there is no data. In the absence of established outcome benefits, there are only risks and costs. And I know that's not going to be popular with everybody in this audience, but I have to tell you what I really believe here, that we need to do better. And we don't seem to have the right answers. And maybe some of the newer drugs coming along are going to get there, but I'm going to challenge them to show us. What about more substantial weight loss? So what can we accomplish if we can get a lot of body weight? What I showed you is look ahead 4 kilograms, sibutramine a couple of kilos, lorcaserin, almost nothing, maybe 1.5, 2 kilos. These drugs just don't help people lose much weight. What about more substantial weight loss? Well, I'm going to show you some recent data, and I bet you many of you haven't seen this paper yet, but it's really pretty amazing. This is a retrospective matched cohort study in patients with severe obesity with a body mass index of over 35 and diabetes. The surgery was performed over a period of years in 4 integrated health systems in the United States, 5,300 patients. They had 14,000 well-matched control patients that were matched across a wide variety of characteristics. Most of them underwent Roux-en-Y, 17% sleeve gastrectomy, et cetera, and the outcomes were compared with usual care. This was published in JAMA this year. Please read this paper if you haven't already, because the bariatric surgical patients had a hazard ratio for coronary disease events of 0.64. Now look, I've been practicing in this field for about 40 years, something like that. And with statins, we get a 25% risk reduction. A lot of the things we have, we can get pretty good risk reductions. A 36% risk reduction is just a whopping big reduction in risk. Now, these are diabetics. This is not a randomized controlled trial, which is one of the flaws of all of this. We need RCTs, and I hope we can come together, all of us, and do a large, multi-center, global RCT on the effects of bariatric surgery on coronary heart disease. But barring that, this is the best data we're going to have. Macrovascular events, all kinds of macrovascular events, a 40% reduction in these p-value less than 0.001. Published in JAMA, very good, very well-edited journal. Look at how quickly the Kaplan-Meier curves separate. Almost immediately, the benefits are observed. It's really an impressive result. And then finally, all-cause mortality. The p-value on all-cause mortality is less than 0.001. This was not pre-specified. That's why I put in italics there that it's post-hoc. But a post-hoc analysis, it wasn't the endpoint they pre-specified. There was a 2/3 reduction over 7 years in all-cause mortality. Ladies and gentlemen, if together we can figure out how to get people to take off a lot of weight, these data suggest that we can have an amazing effect on cardiovascular death, stroke, myocardial infarction, and these feared complications of obesity. So we made great progress. Cardiovascular medicine story is one of the great stories of the last 40 years. Look at in orange circles, the rate of deaths per 100,000 population from 1945 to 1997 went down, and they started to level off. And I am sorry to tell you that these rates are beginning to go up again. Almost everybody agrees they're beginning to go up again because of the obesity epidemic. That's why we need to work together on this problem, because it has basically stopped progress in treating cardiovascular disease. In fact, this success was so remarkable that Doctors Brown and Goldstein, when they gave their Nobel laureate lecture, they won the Nobel Prize for discovering the LDL receptor. They wrote a piece entitled "Heart Attacks Gone with the Century," and they meant the year 2000. This was 1996. They said, heart attacks are going to be gone at the rate we're going, are going to be gone by the year 2000. But Brown and Goldstein didn't understand the powerful effects of the contemporary diet in Western countries, particularly in America. And so to illustrate the problem, I've actually traveled all over the world trying to find the world's most atherogenic food. I went to Asia, I went to South America, I went to Europe, and I finally found it in Scotland, and I want to share it with you. So this is the most atherogenic food in the world. It's a deep-fried Mars bar. And what you do is you take a Mars bar and you batter it, and then you deep fry it in lard. It really does exist, by the way. And it comes out as this nice gooey mess. You then eat it, it goes straight to the left main coronary artery, and then you die. And we have no antidote. We have no antidote for the deep-fried Mars bar, but it certainly ends up in that visceral fat, driving up triglycerides, driving up CRP, driving up blood pressure, and driving coronary artery disease. So then let me summarize with a summary slide. I think it's unquestionable that obesity rates increases rates of coronary disease, heart failure, stroke, atrial fibrillation, and mortality. That it is abdominal obesity that is more closely linked to adverse outcomes than BMI, primarily because of this metabolic activity of the visceral fat. Cardiovascular risk is increased even in physically fit and metabolically healthy obese patients, but to a lesser extent. So again, encouraging physical activity, even if people don't lose weight, may help them avoid the disease that I treat. The mechanisms of harm include glucose intolerance, you know it better than I, hypertension, inflammatory risk, increased triglycerides and low HDL, and a bunch of other things. Weight loss does tend to reduce risk factors, but only very substantial weight reduction has been linked to reduced cardiovascular risk. Until we have better ways to do this medically, what we have to do is try, and the good news is that there are outliers. You know this better than I. There are people who you get into a program, a lifestyle program. We have to figure out how to do lifestyle programs better. We need to understand the drugs better. But there are going to be at least some people that are going to lose 10, 15, 20 kilos of weight, maybe some people even more. And those people probably are going to have a profound cardiovascular benefit. The problem is we've got a problem that affects tens of millions of people, and we're going to have to find a societal approach to this. But we share these patients. Let's work together on trying to make them better. Thank you for your attention.